Hello and welcome to another episode of the Synapse e-learning series as part of an e-learning program. With us today we have Dr. Kelvin Cortis, a consultant radiologist with a special interest in hepatobiliary radiology. Thank you, Dr. Cortis, for being with us here today.
Thank you, Gabriel.
He will be elaborating with us on interventional oncology, and I would like to stress the multiple modalities which exist in this branch of radiology. And maybe you can take us through each different modality.
All right, so we usually divide intervention into arterial and non-arterial intervention, or vascular and non-vascular intervention. And the commonest treatment modality that we use locally is the so-called transarterial chemoembolization. And here we're implying two different things. So we are delivering chemotherapy directly into the liver, but we're not treating all of the liver. We're just treating the problematic area. So just the tumor or the tumors if there's more than one tumor. And besides that, after we give the chemotherapy locally, so we're giving a small dose of chemotherapy into a small volume, making it a relatively high dose, okay? Just locally, yeah. So after we give the chemotherapy, we go on to embolize the feeding artery. Embolization essentially means that you're closing off the feeding vessel, and by doing so, you're starving the tumor from oxygen. So two different things being done in the same procedure, chemotherapy administration and embolization. Obviously, not all liver tumors should be treated with transarterial chemoembolization, which is commonly abbreviated as TACE. And we only treat certain types of tumors following discussion at the multidisciplinary meeting, which locally happens every Wednesday at Mater Day. And the two main types of tumors, liver tumors, that we always speak about are either primary liver tumors, so the commonest would be hepatocellular carcinoma, or metastatic liver tumors. So the commonest in that case are colorectal metastasis. So with regards to TACE, TACE is very commonly used for hepatocellular carcinoma with two main objectives. If it's a small tumor, the objective might be treating the tumor altogether, and you get a very good response usually. Sometimes you also cure the tumor completely with TACE. But in larger tumors, the objective is different. So in larger tumors, you can either try to downstage the tumor to maybe make it resectable or ablatable. We're going to speak about ablation very soon. Or else you can bridge the patient towards transplantation. So if a patient is eligible for transplantation, and if that particular patient has a tumor, there's obviously a waiting list of around 1, 2, or 3 years, depending on the case. And if you manage to control the tumor in the liver until the patient is transplanted, obviously you're leading the patient towards a cure. Always depending on the size of tumor and on the number of tumors in that particular patient. So that's TACE. We obviously do imaging before and after TACE to see, to objectively measure the response. There are standard criteria to do that.
How long do you take until you do the post-intervention imaging?
So usually between 6 to 8 weeks after the treatment. It depends. If it's a small tumor, you do that 6 to 8 weeks after. If it's a large tumor, you know beforehand maybe that you're going to need multiple sessions of TACE
prior to this.
And you might opt to treat the tumor 2, 3, 4 times, and then 6 or 8 weeks after you do the control CT scan or MRI, because obviously MRI is becoming more and more important. Locally, it's the most commonly used imaging modality for the liver after ultrasound. So it's commoner to do MRI than SCT for the liver. Then the second group of arterial directed therapies, so we're still speaking about local regional therapy, is the so-called SIRT, selective internal radiotherapy. Sometimes this procedure is referred to as TARE, transarterial radioembolization. Now here, the principle is very similar to TACE, so you're trying to treat only the affected portion of the liver. or if the liver is diffusely involved, you're just treating the liver, you're not treating any other organ. But instead of administering chemotherapy, you're administering radiation. So in this case, we have small beads which fly directly from the production facility. Before it was Singapore, now it's Germany. Obviously, since we're speaking about radiation, there's a half-life. As soon as the beads come to matter, we have a time period where we have to treat. Otherwise, the radiotherapy will become ineffective. So this is different. The patients which we usually treat are patients with inoperable colorectal metastasis, which cannot be ablated. So the patient cannot have surgery, cannot have ablation, and these patients would have failed first and second line chemotherapy.
Okay.
So this is a treatment option for patients with no options. Okay, it's unlike TACE, which sometimes is curable. Most often with CERT, we're not curing the patient, but we're prolonging.
So it's more of a palliative technique.
Exactly, it's more of a palliative technique. And if you select your patients in the correct manner using international and European guidelines, you're prolonging the patient's life by around 22 months. So obviously we're doing that locally, we're selecting the patients, and it's not a common procedure. Unlike TACE, we do about 60 TACEs every year, but we do around 5 CERT every year. So it's much less common because these are patients who would have failed multiple other treatments. With CERT, you're delivering radiotherapy just to deliver. It's, again, a relatively small dose, but since you're delivering only to deliver, it becomes a very large dose for the tumor. And since the half-life is not very long, and also the radiotherapy doesn't travel very far away from the beads, you're only treating the area of concern. So it's a very safe treatment modality. And locally, we're doing that on a named patient basis, so it's not officially a service which is being offered, but obviously we're still in the process of reviewing the European guidelines and all that.
Apart from these arterial interventions, there's also ablative therapy as well.
So ablative therapy is very different. So instead of trying to go into the feeding artery or the feeding vessel of the tumor, you're actually putting in an antenna into the tumor itself. Most often it's a microwave or radio frequency antenna, so an antenna which emits microwave energy or radio frequency energy, and you're putting that into the tumor. So if most often you try to put it in the center of the tumor, and locally we use microwave, and the microwave energy comes out from a focal point from this antenna, and it literally burns out the tumor. Obviously this is very understandable. There's a size limit because here microwave energy cannot travel for extremely long distances, so usually we're treating primary or secondary liver tumors which are less than 3 or at most 4 centimeters. Okay? So it's well proven that ablation is as effective as surgery in tumors which are less than 3 centimeters. Sometimes if we have patients with inoperable liver tumors larger than that, we can opt to do TACE, downstage the tumor, and then subsequently ablate it.
Are there any particular contraindications to this form of intervention?
Yes, so the commonest contraindication would be extrahepatic disease. So it wouldn't make any sense to ablate the liver metastatic deposits if the patient has disease burden elsewhere. Another contraindication is the number of lesions. So obviously the less lesions, the better the prognosis. If you're ablating a patient with a single deposit, the outcome is usually very good. There's a good chance that you're going to cure the patient. But if you're trying to ablate a patient with, like, say, 8 metastatic deposits, then the results are poor. So usually 5 is our cutoff. And another contraindication would be poor general condition of the patient in general. With radiofrequency ablation, a contraindication would be having a pacemaker because it would interfere with the pacemaker. But with microwave, that's not an absolute contraindication. As long as you're away from the pacemaker leads, you should be fine. Then there are other forms of ablative therapies. So you can get cryoablation. That means instead of heating the tumor with microwave, you're heating it to around 180 degrees. With cryoablation, you're cooling it to extreme temperatures. And that's also very useful in renal tumors and in other tumors in general, but there's a lot of overlap with microwave ablation. So usually with microwave ablation, you can treat most tumors, less than 3 or 4 centimeters, as we were saying. Another form of ablative therapy is reversible electroporation, where you're not heating the tumor at all, or you're not cooling it at all, but instead you're disrupting the sodium-potassium pumps in the tumor and causing apoptosis without heating. That's still under study. Locally, it's not available, and the main role of reversible electroporation seems to be palliation, not cure, as with other ablative therapies.
With regards to recovery time when it comes to ablative therapy?
So in theory, it can be done as a day procedure. So the patient can come in the morning, have the ablation done, and go back home the same day, even with TACE and CERT. But most often, as a precaution, the patient is kept for one night following the procedure.
And that being said, so the patient is then discharged to the community, and he will probably then benefit from care by his general practitioner,
Exactly.
by his local medical professional. Are there any particular complications which may happen, or warning signs which we should know about?
So the complication we fear most would be bleeding. You're obviously putting in a needle in, and there's a risk of bleeding. I must say it's a very rare complication. So it should happen every 200 or 300 patients. The commonest complication, I would say, is superimposed infection. Since you're treating these tumors and causing necrosis, you're left with a clump of necrotic tissue inside the body, which has to be resorbed. Most often, there is no superimposed infection, but sometimes, especially if the patient is diabetic, for example, or for example, if the patient has an incompetent sphincter of body, if the patient had previous ERCP or previous biliary surgery, there's quite a risk of infection. And if that happens, obviously the patient would have fever. It's normal to have fever after ablation. Low-grade fever is normal for a couple of days up to a week. But if there's a high-grade fever which persists, then the patient should be referred for imaging to see whether he has an abscess. Because if that's the case, we need to drain.
It's not something which one can try to care in the community. So
if it's a small ablation, a small abscess, it can be managed through oral antibiotics. But if it's a larger abscess, then obviously you would have to either drain it or else drain it and give systemic antibiotics.
Exactly. Are there any other interventional techniques which you wish to emphasize upon?
Well, so then we can speak about palliative techniques such as percutaneous biliary stenting. So the first approach to benign and malignant biliary strictures is the endoscopic approach. But that's not always successful. So when our colleagues, the endoscopists, are not successful in bypassing a stricture, we can do the same thing percutaneously. So we're accessing the biliary tree, which is often dilated in these cases because there's an obstruction. We're instead of going from below upwards, we're doing the exact opposite. We're accessing the biliary tree from the liver, going downwards and crossing the stricture. And obviously, we in these cases, in palliative cases, our main aim is to relieve the jaundice, because jaundice causes a lot of discomfort to the patients, obviously, and also it's associated with morbidity in itself. It's predisposed to infections and all that, and to cognitive disorders. So in these cases, we're putting a biliary stent to enable the liver to function normally, and by doing so, the patient would get rid of his jaundice.
And this is mostly done as a palliative procedure?
So most cases are done palliatively, but sometimes you get patients with benign biliary strictures. And most patients with benign strictures would have been operated before. So for example, these are liver transplant patients with benign strictures at the biliobiliary anastomosis. And sometimes you get patients who had Whipple's procedure for obviously a malignant etiology, but then they develop a benign stricture at the anastomosis, again at the bilioenteric anastomosis.
So that would warrant this use of this technique. From your end, as a final comment, how do you see interventional oncology develop in the coming years?
I think interventional oncology has been successful simply because it's resulting from a multidisciplinary approach between oncologists, radiologists, gastroenterologists. And obviously this is a minimally invasive treatment. Since we're treating tumors locally, we're avoiding a lot of side effects. I think it's one of the weapons that are available in oncology, in conjunction with systemic chemotherapy and other things. And I see it developing as a very strict collaboration between radiologists and other professionals. Obviously, each patient would have the best modality, the best treatment modality that is suited for his or her particular condition.
Thank you. On that note, thank you for being with us here today. I hope that through this brief e-learning program, we have helped you to further elucidate your knowledge on interventional oncology, and we advise you and suggest to keep on following us on the Synapse Facebook page for more information. Thank you.
Thank you.